Okay, so we've got Northern Cape, Eastern Cape, Western Cape. Am I missing a province? Free State, 4 provinces. That's fantastic. Okay, good. So let's talk a little bit about the South African health system. Yeah, I'm going to move it. So before we begin, I just want to check in with you. When I say health system, what's the first thing that comes to mind for you? Anybody? What do you think I'm talking about? Hospital, okay. So hospitals are part of the health system? Services. Okay. Services like operations, HIV treatment, TB treatment, okay? Okay. So what actually gets done when you go into a facility? Okay. Sorry? Policies, yes, the guidelines that determine what treatment you get when you go with a broken bone or with a stomach ache, okay? Yes, so the workers within the health system who are providing the care. Anyone else? Patients' rights within, so there are those that are using the system that have rights in terms of what should be provided. Okay, so in South Africa, we have 2 health systems, okay? And I'm going to speak about each of them separately, but they connect to one another. So the first system I'm going to talk a little bit about is the public health system. So South Africa has 2 health systems. Do we spend, how much money do we spend on healthcare in South Africa between the 2 systems? Anybody have any idea? So when we talk about how much we spend, it's usually a percentage of all the wealth within the country. And one way of measuring the health is a thing called the GDP, the gross domestic product. I don't know if you've ever heard that phrase, GDP. It's a kind of measure of all the wealth that's generated every year within a country. So some countries spend a lot of health on healthcare and some countries spend very little. Does South Africa spend a lot or little or in the middle? Any idea? Okay, so some say a lot, some say a little. We're actually in the middle. Yeah, we're in the middle. So we spend 8% of our GDP on healthcare. So a country like Pakistan, for example, spends less than 2% on its healthcare. A country like Cuba spends over 12% on healthcare. A US spends about 14% of its GDP on healthcare. So that's just how much is spent on healthcare. Now, the interesting thing about this, we've got a middle range expenditure on healthcare, but remember we've got 2 health systems, and we spend some of it in public and some of it in private. And I'm going to speak a little bit about that as we go. So let's park the private sector for now, but to let you know that 4% of the GDP is spent on public health care. So half of all the money that we spend in South Africa is spent on our public health system. Okay. So what is the public health system? What is it made up of? We have how many thousands health facilities in the country? Any idea? How many hospitals do we have in the public sector in South Africa? Any idea? Any idea? Okay, there are many. There are many. There are many. So we have 4,200 health facilities in the country. Now, health facility is not just a hospital, okay? So there are many different kinds of health facilities. We all know about the big tertiary hospitals, okay? So you have tertiary here. Can you give me an example of a tertiary hospital? Yeah, so Groote Schuur Hospital. In the Eastern Cape, what would it be? Nelson Mandela, Cecilia Makiwane in East London, and Freya. I think one of them is a regional and one of them is a tertiary, but I'm not sure between Cecilia and Freya. Nelson Mandela's tertiary is tertiary. Okay, and that's based in Mthatha. Okay, what are we missing? Northern Cape. Northern Cape, it's Kimberley. Now, I think Kimberley is actually a regional hospital. I'm not sure that, but it's got tertiary services. But that's your biggest hospital. So Kimberley, well, it's not actually Kimberley, it's Robert Sobukwe. Robert Sobukwe. Um, Free State National. In Free State, it is Universitas. Yes, Universitas. Okay. So that's, do you have a red coat? Yes.
Yes.
Okay. So that's the tertiary. Okay. And then just outside of that, we have what we call regional hospitals. So regional hospitals are not as big as tertiary, but they are sort of in between. So is Mthatha General not the old? Oh, it's not, and then Mthatha General. Okay, Mthatha General. And in Cape Town, what would it be? Karl Bremer, Mthatha General. Khayelitsha is a district hospital, actually. Yeah, though it's big enough to be a regional. Yeah. Somerset Hospital is a regional hospital. Northern Cape, I don't know. What's the regional hospital in Northern Cape? You have a district, because I think Kimberley maybe is not the R. What is it called? Okay, all right. And then Victoria is actually a district also. So there are not that many regional hospitals. So Worcester, okay, there are about 50 regional hospitals in South Africa. 50 in total in the whole country. There are about 50 regional hospitals. And then after the regional hospitals, or before them, we've got the district hospitals. How many health districts are there in the country? You know, we've got a district health system base. So there are 53 health districts. This is the way that the health system is organized. But there are about 250 district hospitals. So the district hospitals are the smaller hospitals. So on the West Coast, it would be Westvliet, for example, or Victoria Hospital in Cape Town. I'm sure there's a hospital in Uppington, which would be a district hospital. So these are the smaller ones. Holy Cross, yes. Sorry? Berkeley, yeah. So those are the smaller hospitals, and there are about 250 district hospitals. Got a lot of health infrastructure in the country, hey? So we've got 250. And then before you get to a district hospital, on the outer circle is our community health clinics, CHCs. I don't know how many there are. There are a lot. There's community health clinics and also health centers and then health clinics above that. So if we had a really good health system, you should be able to walk to your health clinic. And then from your health clinic, you should be able to be referred to a community health center. And then if you need to go to a district, you go to district. From district, you go to regional, and regional, you go to tertiary. Okay, so that's the healthcare pathway. So if someone has a symptom like I've got chest pain or I have a lump that I can feel, they would first go to, let me use an example. So let's say in the Northern Cape. Where's the Northern Cape Health Forum? Okay, so with the first place in your community that people go to, what is that facility? So there's a clinic. Is it only during the day? And if you, at that clinic, do you see a nurse or a doctor?
In some cases, in other clinics, there's 1 day or 2 days.
With there's a doctor also. Okay. And then from that clinic, if you have too complicated a problem, where would you go to? What's your district hospital? Collie Foster Hospital. Okay. And from Collie Foster, what's the next one? Kimberley. Okay. So can you see good things about having this way of coming into a tertiary hospital? Any bad things? Let me start with any problems people have experienced going from health clinic, community health center, district, regional, tertiary. Has anyone experienced any problems on that referral pathway?
Yeah, I would say we do have a problem
Mm,
because we find out that we are next to CHC,
mm,
Community Health Center, but there are clinics that are around.
mm,
So even if I'm next to
mm,
CHC,
mm.
but when I'm going there, you see that there are many people, but they are coming from the health clinics.
So it's overcrowded. So, okay, so let's call this the pathway. And I'm going to say the things that are not working and things that work well. Because, I mean, if you look at it on paper, we've got a great public health system, right? But some of the things now you're saying, so you get there and it's overcrowded. Do they sometimes finish the queue at a certain time and say you must come tomorrow? Some places do, some places don't. So let's say you're very sick, it's going to be a problem, then you must come again, maybe pay transport, maybe take off work for some people. Mm. Okay. Okay. So what is that called when they do that? When they say, okay, who's bleeding and who's just got a headache? It's called a triage system. Okay. So I would say that's a positive thing. So it's a triage system because let's say I've got just sprained my ankle and I come into the clinic, but somebody next to me is vomiting blood, for example. So you can't say, I was here first and I want to be seen first and not that person. So triage is important so that you can find the people that are more sick and they get referred quickly. So triage is a positive system of positive thing of a care pathway. Overcrowding is a negative. Any other negatives? Does anyone? Yes.
Other negative system in the clinics,
Yes.
especially the local clinics, they start late.
Okay.
Instead of starting at 7 o'clock,
Yeah.
they start at 9.
Okay.
1 hour waiting for them, too tired. People are queuing outside there, they're sick.
Yeah.
It's raining, it's cold, windy,
Mm.
so it's affecting them.
Mm.
That's another thing.
And also they're queuing outside. I mean, if you're coming and you're not feeling well, it's not a very comfortable place to be waiting when you're not feeling well. Okay. So why do you think that's happening? Why are people doing that? Starting late, long breaks? Are they just lazy? Are they don't care?
They don't care.
They don't care. You think so? Okay, let's hear. Okay. Okay. Mm-hmm. Okay. Okay. Really? Okay. The folders and yeah. Okay. Okay. Yeah. Okay.
Another thing is that
I just want to go this side. Yeah. Yes. Okay. Fatigue. Because remember, many of the people working in the clinics, are they from outside of your communities or are they from local? Outside. Okay. Why is that? Both. Okay. Both. Okay. Because sometimes, I mean, if you're working in the clinic or you're a community member, community members can be working in the clinic also. So something is happening in the system that's making them not do as much as we would like them to do. Okay. One more. Okay. Okay. Mm. Okay. Okay. So coming into the health system through a care pathway which starts at a primary clinic works well if the primary clinic is working well. Is that right? So there's some problems with how the primary clinic is working at the moment. I want to ask a question. I want to ask, so do you think people are getting better care at primary clinics or at tertiary hospitals? It's a loaded question.
I think I would say it's primary.
Okay.
When you have a complicated
Mm.
situation, then they will refer you
To tertiary. So that's the
to get help there.
we get help there. So that's what we would like to see. Is that what people are experiencing? So yes and no. Okay, we're going to take a short pause so you can talk to the person next to you. I want you to think. Okay, before we pause, come with your comment.
I will also say it is the primary,
Okay.
but the challenge is the staffers are too relaxed
Okay.
through the years. They come here for 30 years.
Mm-hmm.
So then, to me as a community practice worker, I think reshuffling is needed.
Moving people around.
So then, I think let's say I'm here for 30 years,
Mm.
and nothing.
Okay. Okay. So what I'd like you to do quickly is to just three of you at a time, just turn to the people next to you. I want you to talk about one example where the care pathway has worked well. In other words, someone went primary, secondary, tertiary, it worked very well. And one example where it did not work well. If you know of somebody, someone's cancer was missed or someone got too sick and waited too long. If there is a negative example, I don't know, maybe there isn't, maybe everything is working well. So just quickly, three of you, just turn for 3-4 minutes. I think it's the three of you. And just talk through two examples. One good, so it's the three of you together. I think you can be four. Yeah. So 3, 3, 3, and then it's the three of you here. I think we're going to be four here. Okay. Maybe he just. My phone, I don't know where I've put it. It's like a chronic problem. Yeah, not really. I've checked. I'm always, no, I'm always putting it down. Yeah, I'm always putting it somewhere. It will be somewhere here. I just wanted to check time actually.
You want to check time?
Mm.
Where did you get your tea?
I came here.
Oh, you got it. Oh,
What I'm saying, the services that
I can say there are a lot of services that are never
okay, so like basically like a diocese, like our diocese.
Okay, let's come back together. Is it too soon? Is it okay? Okay, okay. Are we fine? Can we come back together? Okay. All right, everybody, let's come back together. So, from this side, I want to hear positive stories of the care pathway, and then this side, you can tell me. I'm hoping there's nothing on this side, but you can tell me negative stories if there are. Okay, let's go quickly. Just what came up. A care pathway, has it worked well for anyone that you know? Family? No. Okay. All right. What went wrong? What went wrong?
So the pathway of referral for us
Yeah.
is in our community is different to the pathway.
Okay.
So they call the CHC a clinic.
Okay.
We call it a day hospital.
Okay.
So the pathway of referral for us from our day hospital takes a long time, because what we found is that at the end of when the person gets referred to the district hospital or the tertiary hospital, because there's no referral to a regional hospital from our area, from Heideveld to a regional. So we get referred.
The Heideveld goes to Mitchell's Plain,
It's district.
and then district you go to Grooteskier. Yeah.
So that is the pathway of referral. But when a person comes to the CHC,
Mm.
they come there with something that is they know there's something wrong with their body, and it's been wrong. That problem was there for a while, and it took them a while to get to the CHC. Then they get treated with disrespect sometimes.
Okay.
The nurse, the PN would or the CNP, she would say no, this is not necessary. They give you Benadryl and they send you home. You come back a month later with the same problem. Yet again, they don't treat the problem. At the end, when they eventually refer you to the district hospital,
It's late.
it's late. So then you either had a heart problem, or you have blocked arteries, or you might have stage 4 cancer.
Okay.
So that pathway of referral needs to be looked at. How can we get these people at the staff at the day hospitals to look into, is it really a pathway of referral? Do we need to refer or get a second opinion within your system? Because you do have your qualified doctors.
Do you think it's knowledge, or do you think it's being rushed?
I think it's more knowledge.
Knowledge,
Or
or both?
both, yeah.
Okay. A positive.
Can I tell my story?
Yes.
A positive pathway of health is that one, sometimes in my clinic, I request that sister to refer me to the doctor, because I realize that they cannot cope with my problems. Fortunately, she allows me, then refer me to the doctor, and I met best and good doctor in the hospital. Really, he attended me and he referred me to a Nelson Mandela hospital. I've done also many tests, so becoming well.
Okay.
Because if you can see me, I'm very, very healthy. Because on that doctor.
So that's good. So what worked well there is that, okay, the nurse didn't know, but she was open to you requesting, please can you refer me? And then you met a doctor who was very good, who listened, and also could access the tertiary hospital. And then you got to the tertiary hospital and all the tests were done. So that worked well for you. Okay, good. I'm still looking for good stories on this side.
Okay, it happened with my child. so I'm the one looking after her. So she was attending a PHC from when she was born.
Mm.
Yeah, until when she was 14 years.
Mm.
Yeah. She had ear problems, both ears. At school she was failing and all that, but at the clinic they just kept giving her the drops.
Mm.
Until one day then I was angry with them. That time I was still working at the clinic. So I was angry at them and I asked them to refer her. They made me appointment not to the bigger one at Kimberley. I didn't
Okay.
go to Queen Foster, and then they directly made a referral to Kimberley. When we got there,
Yeah.
at the ear clinic, they found out that the eardrum was
So there was a hole. Yeah.
so the infection got to the skull.
Ah.
They had to remove a piece of her bones
Right.
that was infected and then give her a new eardrum. But now, well, she's doing perfect. at
Wow.
school.
Okay, that's a very good story. And so here also you were persistent. You
I was
didn't give up.
insisting.
You were like, there's something wrong, there's something wrong. But then someone listened to you
Maybe
and you could,
because I was working there, maybe
maybe.
if I wasn't working there,
Well, let's just stay positive. and then at Kimberley Hospital there was a specialist who could look in the ear. They had equipment to see, and they could access a theater with someone who knew how to do the operation, and they could. So that's a very good story. And now she can hear, and so she can learn.
she's doing well
Yeah.
at school.
Okay. 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 Lovely. Okay. In this group, or you can share one that didn't work also, if you don't have a positive or negative story. Okay.
I had a lot of pimples on my face, so
Mm.
I used to go to the clinic. So they gave me treatment. Oh, pick up. I used to have lots of pimples on my face, so I went to the clinic and they gave me some medication, but that medication didn't treat me well.
Mm.
And, I usually, maybe when I drink the medication, I will be dizzy. So I told the nurse that this giving me side effects, this treatment, it is not treating my pimples. Then the nurse referred me to Nelson Mandela Hospital. So I went there at dermatology and they were giving me the right medication and it helped me because there's a difference on my face.
Okay. So you managed to get to see a specialist that, and then when you go for your medication now, do you go to Nelson Mandela or you go to the clinic?
To Nelson Mandela.
Okay. 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 Good. All right.
The positive one is at the tertiary.
Mm.
While I was in Vistas, I had two scars on my stomach that wasn't even with, couldn't even self-hold. They were not healing for 2 months. And then they organized a stomach sister who will take care of the wound. And it took just a week and the wound was closed.
Okay.
Like and the attention that I was getting there
Yeah.
was the top ones.
Right.
Yeah.
Okay. That's fantastic. So the right kind of care can sometimes mean it's a much shorter time that you need to be, that you're sick, because the wound healed in a week as opposed to months and months.
Even though I stayed there for a long time,
Okay.
the healing just took some
And that was from a nurse that knew how to treat the wound. So it's not only doctors that, yeah. Okay, good. Okay.
Okay, well, for us, it's not a pathway, but more an experience
Mm.
that causes most people to choose tertiary instead of primary
Yeah.
because of primary's lack of management and poor accountability.
Mm.
You see, what happened is there was this old man. He was once taking a shower at his house and he fell and he hurt his shoulder. And then this old man, he just thought it's a minor thing. He didn't really. But then as time went by, hey, this shoulder is hurt. So he told his son. Then his son, he took him to the clinic. And then what happened there? Then they just looked at him. They gave him some meds. But as time goes by, this shoulder, it still hurts and it's very painful. The son can see his father here is dying of pain. So he informed us, and then we took the medical management, and the management asked us to please bring the father again. When the father came, the father was referred to the bigger doctor, you got this doctor in charge,
Mm.
and then the doctor in charge took the man to X-ray,
Mhm.
only to find out that this man was.
It's a
armed.
fracture.
It's
Mm.
exactly, you know. So it's what happened.
Mm.
Yeah.
So they missed it the first time. So that was the negative. On the positive, when you went back, someone did, and there was X-ray at the facility to
Yeah,
do.
there was X-ray
Okay,
facility to do,
okay,
yeah.
okay.
But the first time they didn't take him to
They didn't take him for X-ray, and maybe didn't examine that arm properly.
Exactly.
Okay, okay. I just want to get maybe 2 stories on this side quickly because I'm mindful of time. Who is like burning? Oh, okay.
Now, I would say it's a negative. Because you go to the primary care, then from the primary care, they will refer you to CAC,
Mm.
then from CAC to district.
Mm.
So there's a guy who went to a clinic, a nearest clinic, and he went there for help, and they referred him to CAC, which is in my village. And when he arrived there, they said he must go back to the clinic so that they can treat him there.
Mm.
He was having something here in his lungs, but they didn't see anything to him.
Mm.
That what is happening. So they referred him to CAC. And then the CAC, we went there the other day. I was there also there. So when I saw that guy, he was sleeping like on the bed, on top of the bed.
Mm.
And I asked him what is going on. They were that guy to the CAC. He told me that he's been sick.
Mm.
He doesn't know what is happening, but inside
Mm.
of him,
Mm.
there's something. So I called in charge for a CAC charge.
Mm.
I went to him and asked him why is this man not being helped
Mm.
here? Because yesterday he came here and we are using transport money. He doesn't stay there.
Mm.
It's 30 rands from his return is 60 rands
Mm.
from his village
Sure.
to CAC, then from CAC
Back.
they didn't help him. Now we had to end the charge. They said charge is not around.
Mm.
Charge is not around. We went to called sister in charge there,
Mm.
and they had an attitude
Mm.
about this whole thing. This guy, he didn't want to be helped here.
Mm.
He was talking, what those
Mm.
things. So up until we found a number of the regional office,
Mm.
we called the guy who was he used to manage the CAC. We called him and told him about the story, and that guy called the regional hospital.
Mm.
And they went to, they called that guy to the CAC. He went there. They waited for ambulance up until that guy died there.
Mm. Sure.
So he died there. In the morning, they called me as I'm a leader in the community. They called me that there's this thing that happened here.
Mm.
And the guy, I knew that guy. I saw him 3 days back.
Wow.
I saw him second day. He was going there, but they didn't manage to treat him.
Mm.
Up until now, I think there's a case that is going on. The family is suing the hospital. And
Mm.
now, the thing is that the community, they are fighting. They say they are fighting for the community.
Okay. And this is this, which province is this? Eastern Cape. Okay. So that's quite I think we're going to pause on the stories there because I want to speak a little bit about what I'm trying to, the idea of some people are very frustrated that they can't just go and see a specialist straight away. Why must I first go a nurse and then a generalist, and like I can see there's a problem with my dizziness, I must see a neurologist. Now, one of the problems with that, the first problem is that you see that there are very few tertiary hospitals in the country versus district and CHCs. So one thing we could say is, look, everybody must just have access to a tertiary hospital immediately. But there are problems with that. not only because the tertiary hospital will become overcrowded, but because a specialist in a particular area is only knowing their particular area. They don't always know it's this that I can see. It could be. So if you're dizzy, your dizziness could be because of something in your ear. It could be because something is wrong with your eyesight. It could be because there's something in your brain that's causing dizziness. It could be because your sugar is low. It could be because your blood pressure is high or too low. So if you say, I'm just going to go and see a brain specialist because I think I have a tumor in my brain, you could go to the brain specialist, and the brain specialist checks your brain, and they're like, your brain is fine, there's nothing wrong here. But they maybe don't check your sugar, they don't check your blood pressure, they don't check the other things related to your whole body. And so then they say, okay, no, maybe you must go and see an ear doctor because your brain is fine. Then you go to the ear doctor. The ear doctor just checks the ear, but doesn't look at everything else. And then perhaps you go after that to someone who's just checking the blood pressure. So specialists have a role, but their role needs to be within a system where there are generalists who have already looked at the whole picture. And that's what's supposed to happen at the clinics and at the CHCs. But the problem is sometimes there are not enough people there, and they can't refer you quickly enough. So we've only talked about things that are not emergencies. If you have an emergency problem like you're in a car accident, you're not going to start at your clinic and then your CHC. You're going to go straight to a casualty at a district hospital. Some CHCs have got 24 hours as well. Now, the reason I'm saying this is because I want to talk now about how the private health system works. And this is important because when we talk about NHI, people are often saying that the private system is the one that we want because you can see a specialist quickly and it's easy and all of the hospitals are there. So I want us just to hold this idea of a care pathway. Some of the good things with a care pathway, that you've got generalists that see you and also CHC clinics that are close to you. And some of the negatives, that if you don't have the right information and skills at your primary care level, you can get delayed, right? So let's talk a little bit about the private health system. Yeah. Ah. So you don't all come at 7 in the morning? No. Is everyone experiencing that, appointments? Other provinces?
The appointment system that they've implemented.
Yes, in the private hospital.
No, in public?
The appointment system for us in Nedertal with the help of the health committees and their input, they created an appointment system where everyone gets appointment time, date, and then you come on half an hour or 45 minutes before your appointment time. So for instance, if you have 7 o'clock appointment, you don't have to come and sit there 5 o'clock and 4 o'clock in the morning. So that system works for us now. So there's lesser people waiting outside in the queue and also inside in the waiting area. So that system works.
It's helping.
So the system with that area is working, but then you find a short staff and people sitting, waiting longer hours for
Even
doctors
though they
and
came,
nurses, even
yeah.
though they had been there on time for the appointment. So that is
Yeah.
still
It's still a problem, yeah.
But we all know about all these budget cuts and stuff.
Yeah.
So that is working.
Number of problem with the appointments is appointments from primary to special.
Mm.
If you have an appointment from the CHC to go to other skills, then it can take it up to 2 years.
Yeah, months and months of waiting. That's a really important point. So the care pathway only works well if the primary level of care is well resourced. Okay, so you need to have enough people there, a good place to wait, and then the second thing is you have to have people working there who know how to diagnose the different conditions. Oh, okay, it's dizziness. I need to check sugar. I need to check blood pressure. I need to check in the ears. And then if they find something, so if they know what to do, they need to be able to get you to the right place, regional or tertiary. And you can't wait 6 months or a year to get there. So you need to access the system. So the foundation of the system is not wrong, but it needs to have enough resources in it to make it work. I mean, that's really the point. Last question. Of all of these stories, how many times did people have to pay? No, negative or positive stories when they went to these visits?
Like for instance, if they refer to from CAC
Mm.
to the hospital,
Mm.
when you arrive there, they're going to ask you for money
Mm.
to open a file.
Okay.
And that is not happening once.
Okay.
If you open the file,
Yeah.
you'll expect that, you'll expect that next year,
You must do it
they're
again.
going to use that file. But when you arrive again,
You have to pay.
you want money to open
How much are they charging for that?
50 rands.
Okay. Is everyone else, so you, in your story, someone had to pay. On this side?
At our place, if that's why when they tell the people to begin at the primary
Mm.
facility, because when you start there and then they give you a referral letter,
Mm.
when you go to district hospital, you're not gonna pay.
Okay.
You started at the primary.
Okay.
pharmacy.
And what about if you're unemployed or on a grant, or are you paying regardless? Everyone is paying.
To me,
Yeah.
to me, last month,
Okay.
I had a file, I think 2 years ago. But when I arrived there,
Mm.
they told me that I must pay money
Okay.
to open a file. And I said to them, I'm expecting that I still have that file. That I opened.
Yeah.
And I told them that I'm not working.
Yeah.
And they'll say, okay, you'll pay it when you have money.
Okay.
And they will write you a ticket.
Yeah. Can I just see by show of hands how many people have experiences where the facilities are free, completely free? Okay. And how many people are, there's a fee that you pay, but if you can't pay it, it's okay, and they give you a slip. They send you a letter. Okay, some. And how many people know of people who have had lawyers' letters and debt collectors? Not many. Okay. So, I mean, most of the care, including tertiary care that happened for some people, most of the care has been free. Am I? Yeah. Hmm.
Yeah, there at our hospital, if you are patient,
Yeah, am I not right? Did it fall?
if you are a pensioner or you're not working, you can come with an affidavit. They don't give you a slip to pay later.
Okay.
They ask you to go and make an affidavit to say you're not working.
Okay. Okay, good. So I'm going to take this as a positive thing. Fundamentally, most of the healthcare within the public sector is free. They are, I mean, at Critis Care, people are asked and charged, and sometimes they are followed up, and it's terrible when it happens, but most of the time it's free. So I want to talk about the private sector, because we need to go through this before we get to tea. So let's talk about the structure of the private sector. Private health. Okay, so remember in the public we said that there are about 400 hospitals, 4,200 facilities, about 250 district hospitals, 50 regional hospitals. In the private sector, there are about 200 hospitals, and they get, what was the percentage GDP spend on health for South Africa? 8%. And how much was on public? Yeah, and on private, it's also 4% of GDP. What percentage of the population uses private healthcare in South Africa? What percentage of people use mainly public versus mainly private? Any idea? Is it 50-50? The money is 50-50. Is the population 50-50? Yeah? More using public. Okay. How much more? Yeah, it's about 85% public and 15% private. There's a little bit of overlap because some people will go and see a GP or pay at a pharmacy that's also private, but it's 15% of the population uses this system. Okay. So let's talk about the care pathway in private, and then we'll talk about some of the differences between public and private in terms of resources. So how does it work in private? If you get sick, what do? Where do people go? If they get sick, they go to a GP. Okay. And then?
medical, medical services.
Okay.
Private hospital.
Private hospital. So the GP is kind of the primary level care. Are there clinics and CHCs? Not really, hey? They're usually just one GP,
Sometimes there's
a center. Mm.
Recently, the lady that was, it came I think last year, but now this year those people they wanted the health forum because they were saying that the no clinic, it's a private clinic, but they reported that the health forum saying that the clinic is not working, you know, and then they fear maybe the people are not aware of something, but it's in a way dysfunctional.
Okay. Is it a private? Okay. 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 In the community, how many people in this room have got a private hospital in their community or close by? 2. Close by being within like 10, 15 kilometers, so Gatesville. Okay. What's the name of the private? Tata Private, okay. So basically just a minority. How many people live in communities where there are general practitioners in their community? GPs. Okay, most people, there are some GPs in communities. So GPs are a bit more accessible than the private hospitals. Who is from rural, anyone from more rural communities? Are there lots of private facilities close by or not really? Okay. Because there's also a difference. Most private hospitals are in the big urban centers. There are very, very few within the rural areas. And this is important when it comes to NHI. Okay. And does anyone have a positive story about the private health system? Lots of silence. Never been there. GP visit. Okay, sorry? Sorry? Yeah. You went to your GP? Yeah? Mm. On your eye. Okay. So that was quite quick and you saw a specialist. Okay.
I went also to a GP.
Mm-hmm.
I had good experience.
Mm-hmm.
The GP provided issue with my eye.
Okay.
The GP in the area where I live nearby.
Yeah.
2 roads.
Yeah.
So it's normally
Yeah. Quite good. And how many people have GPs that refer to the public hospitals? Yeah, that often happens, right? The primary clinic is so busy, so people go to the GP and then the GP writes you a letter to your regional hospital or public. So
There's still a system
Mhm.
at the
Yeah,
CHC.
Yeah.
If they refer,
yeah.
because you still have to go through the non-appointments. It's
Ah.
not making your life easier going to referring you.
So it's not
So you
always
still have to
helping.
go through
Yeah,
the system.
except maybe you've got a diagnosis or yeah.
But for
Okay.
us, we still have to go
You
through
can't
the
really
system.
bypass. Okay. So I'll tell you about some of the positive experiences that people have had in the private sector that I know of because I've seen people use both systems. So with private sector healthcare, you usually get into the system very quickly. There are people who have gone straight to see a specialist. They don't even go to a GP first. They don't do primary healthcare. They go straight to a specialist. And then if going to casualty, you can get treated very, very quickly in the private hospitals. And also it looks nice coffee and it looks nice. So there are lots of positive stories that I'm sure you've heard about in the private sector, but maybe you haven't heard of some of the negative stories. So yes, my dear. Okay. Okay.
You get operated today
Mm.
early in the morning.
Mm.
It's only one day.
You get discharged
whilst
very
you're still in
quickly.
pain.
Okay. Yes. So they're very quick about discharging very fast. Why do you think? Okay, because it's an expense, right? So every day that you spend in. So the fundamental difference between the public and the private sector is the public sector money, that 4%, is coming from where? Where's that money coming from? It's coming from tax, which all of us pay, whether you're employed or not. Everyone is paying tax. If you travel in a taxi, if you buy food, everyone is paying tax because there's VAT, there's a surcharge on petrol, there's income tax, but everyone is paying tax. And that all goes into one place, and then we pay for public health care so that you can mostly have public health care for free. Now, in the private system, where does that money come from? So people are paying, okay? They're either paying cash, which is called out-of-pocket payment. You've heard of that? Or you've paid for insurance, which is your medical aid card. So it's coming from the individual. And the system is being run in the public health system. Is the Department of Health making money and profit from healthcare? No, they can't, right? Because they are fundamentally using tax money and treating. So it's the core thing there is the delivery of the health care. In the private sector, there is healthcare happening, but there is also a business behind it, okay? So the business is that the hospital groups have to be profitable in order to continue to run. And so sometimes you will get policies which don't necessarily support good health care. So some of the policies might be early discharge from hospital. Sometimes that's a good thing, but sometimes it isn't. Some of the other policies, if you were running, so not that everybody in the private healthcare industry is bad, okay? But let's just move with the story for a bit, and I'll tell you about why I think they're not necessarily bad. So if you were running a private hospital, would it be in your interest for people to remain very well, or would it be in your interest for them to get sick? If you own a private hospital, right, and you're making profit, okay. Now I'm not saying that the private health system is trying to make people sick. I'm not saying that, but what I'm saying is, do they have a natural interest in preventing illness? Okay. Which of the two systems is going to have a natural interest in preventing illness? It's going to be a public system because you want to have fewer people coming through the corridors and the doors. So things like vaccination, food security, promotive health programs in schools, those things are going to come more from the public health system. They're going to want to prevent people from getting sick, just from a pure economics perspective, aside from the fact that that's a good and right thing to do. Now, I'm not saying that the people in corporates and private are like, ooh, how can we make the population sick? Not at all. But when they're looking at their priorities are not in prevention and promotion of health. Their priorities are how do we manage illness and disease, right? So when we look at what we do as a country, in terms of healthcare, we need to think about how we shift the priorities of the two health systems in order to do that. So people have had many positive experiences with the private health system in terms of getting really excellent care, but some of the negatives they've had have been the huge bills that come at the end. So even people, you've all got family and friends, I'm sure maybe someone you know who pays a lot for their medical insurance, and they think they are fine and covered, but at the end they go to the hospital and they come up with a 20,000, 30,000 rand bill after all of that. So that's one part that you know about. But another part that maybe you don't know about is that I work in a tertiary hospital, and I'm a specialist in my area, and I have seen people treated in the private sector that have not gotten always the correct treatment. Okay? And that can happen in any health system, but it is important to know that it can happen in private too. Where do the private sector health workers get trained? They get trained in the public hospitals, exactly the same place that all the other doctors and nurses get. So you mustn't have a sense that people are working in public because they're just not good enough to make it in private. It's the same training system. But the one system has got more health workers than the other system. Now, the one thing that the public system has that the private system doesn't have is we have teams. So I'll use the example of cancer. So we sometimes see that people's cancer treatment is not exactly what it should be in private. Often it is, but sometimes not. And that's because in private you might have a surgeon working on their own. You have an oncologist, which is a cancer specialist working on their own. You maybe have a palliative care person working on their own. But in the public sector, you have people working in teams. So they sit together and they say, what is the next correct treatment for this person? And those kinds of processes that we have in public are the ones that we want to protect and improve. Okay. So I'm going to show you a little bit now about how the divide is between the two. So what percentage of doctors work in public? I'm asking you lots of numbers today. Okay. So I just want to tell you that many of my friends work in the private sector. So I'm not anti-private sector, but I'm against this two-system healthcare system that we have now. And people on both sides are suffering, actually. People in public and private are suffering. Not to the same extent, but they are. So doctors, specialists, dentists, psychologists. Okay. Nurses? What percentage work in the public sector? So that, remember, is 85%, 15%. The money? Okay. So it's about 60-40. Which side do you think the 60 is? No. I mean, that's even generous. It's probably more like 30-70. Okay, so most doctors actually work in the private sector. I know, hey? So that, okay. So nurses, it's about the same. Specialists, you're looking more like 25%, 75%. Dentists, it's kind of like 90% work in the private. And the mostly in private. And psychologists, I'm not sure, it's very similar. Wow, hey? So now you can see why when you go to your primary clinic, you struggle to find a nurse or a doctor there. There are just not enough people there. What is going on? What is going on? Okay, so there's one thought that, you know, these doctors and nurses just want to make a lot of money. And so they want to work in private. So that's possible. And time, and also job satisfaction, so that's possible. So can I ask a challenging question? How many doctors in South Africa are unemployed? 1,000, yeah. There are 1,000 unemployed doctors in South Africa. So now what's going on? So we've got a shortage of doctors in the public sector, right? But we've got unemployed doctors. What's the problem? There's work to be done, and there are people who want to work. What is the problem here? Yes? Okay, so if you want to work in a public facility, you need to have a job in a public facility. In order to have a job in a public facility, you need to have a post which is funded, a funded post. So there needs to be a funded job in the public sector. And we have a shortage not just of health, not so much of health workers, we have a shortage of health worker posts. We have a shortage of paid positions within the public sector. And it's important that we know that, because the solution is not to train more and more doctors, which is what we've been doing for the last 10 years. Maybe we do need more as well. But you can't train the doctors and not give them a job in the hospitals and clinics, because then it doesn't help the system. And that's why we have unemployed doctors, because we've been training more doctors, sending them to Cuba, extra medical schools, but we haven't created extra jobs to absorb them into the public system. Because the public sector wage bill is too big, right? Have you heard about this? So they say that we are spending too much money on public services. which is one of the issues around the budget cuts. So when we think about what's the next step to improve the health system, oh, maybe I must give you one more bit of information. Of the posts that we have in the public sector, many of them exist but they're not funded. So about 20 to 30% of them are vacant and people are not in those posts. So the people that are left behind are working extremely, extremely hard. Okay. So everyone is a bit shocked by this. Yeah. Okay. So how would the government create more posts in the public health system? What would they need to do? To increase the health budget. I agree. Who decides on the health budget? Actually, not Parliament. It's Treasury. It's not even the National Minister of Health. Treasury decides on the health budget. So in October, there was a big budget announcement for the next cycle. And you may have heard people saying, oh, it's a very good budget speech. Some people said it's a very good budget speech because we're going to have a very disciplined economy. When they say discipline, what they really mean is that we're not going to increase spending on public services. This is really honestly the truth, okay? So in the last 2 years, for the first time in 20 years, we have had cuts to the health and education budget. We've had a 5% cut to the health budget, which means that the number of posts that we had before are even less now. In my own department, we have lost 12 doctor posts. So if people have left or resigned, they haven't been replaced. At Groote Schuur Hospital, we lost 91 million in posts. And across the entire province, we lost about 900 health posts. That's just the Western Cape. I don't know the numbers in other places. So we've got a major, and this speaks to the advocacy which we'll talk about this afternoon and that James will take you through. We can do advocacy at a local level, and we also need to do some advocacy at a national level. Because how many of you knew that the health budget had been cut? A few, because we've had those conversations. A few people knew. But actually, you're health leaders, right? In your communities, you're health leaders, and you don't know about this. How many of you know that the NHI has been passed into law this year? How many of you know that? Have you heard that the NHI has now been passed into law? Okay. So more of you know about that than knowing that the NHI system, which requires a functional health system, has been passed into law, but at the same time, the health budget has been cut. I mean, does that make sense? Right? If we're talking about equity in healthcare, we need to be increasing what is going on within the public sector. Okay. So 5 minutes to tea. I want to leave you with a little bit of information about how the funding of health works, just so that you have an idea about that. So where do we get our tax from? So it's income tax. What other tax? VAT, yeah. I think that's income, yeah. Anything else? The business people, yeah, that's corporate tax. Mm. 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 Okay. Thanks. No is disappointed about that, but I mean I don't take it too hard because there are many education activists, environmental people that you would expect to know about this crisis in health that don't actually know. And it's about how the media can manipulate our information. So what's important is that the minister has signed off NHI and we are committed to equity in health. But what we don't know is they're actually not actually doing it because they're not supporting health. So it's not entirely your fault. So, okay, but still also write and listen like noises. So there are different kinds of tax: income tax, VAT, corporate tax, and there's a tax we pay on all the petrol that we use. And I'm going to leave you with that thought before tea, because when we come back from tea, we're going to talk about the NHI proposal. And the NHI proposal needs more money than we have now in health. And that money has to come somewhere, and it's got to also come from one of these taxes, right? And there are some taxes that are good for increasing equality, and there are some taxes that make inequality even worse. And that's what we're going to talk about after the break. Can we break now? Is this Tinashe? Yep. Questions before we break?
I've been concerned, there's no influx from the doctors who were at the public, like at the clinic. Now they are running their own business. Is there no measures to regulate that?
You're talking about the private work that some of them are doing,
Yes.
and they're also working public.
No, they've left the public now.
They've left the public and they've gone to private. Why did they leave? You don't know.
No, I was just listening to the fact that now the unemployment rate
Mm.
from the doctor's side,
Yeah.
some are running away from NHI.
Oh, okay. So maybe we must talk about that and what pushes health workers to move to different places. So we are losing some people from the public system to the private, but the private healthcare system cannot employ every doctor, even if they wanted to. There's just not enough population for it. But what we're losing is our very senior specialists that are moving into private, and it's partly because the posts are not being opened up. But I think we've done a lot this morning. So let's take a little break, and we can start with a quick question session when we come back. So if you have questions, bring them, and then we'll talk a little bit about the NHI.